thank you for coming to our talk and the two afterwards. Myself and Bethany are going to talk to you about the alcohol dependence dashboard and the return on investment tool. So Bethany and I work for the Transformation Directorate at NHS England, but we also work very closely with colleagues in the Medical Directorate, and in particular the Prevention and Long-Term Conditions Department. So we started off our journey working in the prevention section there, and the prevention programme was set up largely to deliver long-term plan commitments around tobacco and obesity and alcohol. But we've since become part of a wider team that now includes long-term conditions as well, such as diabetes, cardiovascular disease and respiratory diseases. And that's all under the director, Matt Fagg. So our work on alcohol has centred on alcohol care teams, or ACTs. These are liaison services within acute hospitals, and they improve the management of patients with alcohol dependence. So they aim to provide interventions to help patients stop drinking safely and then to remain abstinent on discharge. There was a good evidence base for ACTs from pilot studies, and this was drawn together by NHS England and Public Health England to create an optimal model for ACTs which standardised the skills and the functions of the team, and also, very importantly, for the rollout, the staff to patient ratio that was expected. And the national rollout was focused on the 25% of hospital trusts with the greatest need, and that was assessed by looking at alcohol-related admissions, looking at mortality and looking at deprivation, and also in conversation with local regional prevention leads. Hopefully that'll stop there and not pick up 4 clicks. So, as is good practice, the ACTs and the rollout will be evaluated, and NHS England has engaged a collaborative to come and do that for us. We also expect that there will be local evaluation by areas who have these teams. But it was also immediately clear once the rollout began that there was a need for rapid information on the ACTs, how they were being delivered, who was being referred, and what the outcomes were. And this was needed by the prevention programme team itself and in the national team, but also by regions, by ICBs and by trusts who were involved in this. So I'm going to now hand over to my colleague Beth, who's going to tell you about 2 tools that she developed which helped to answer some of those questions and other things. So.
There you go. Yeah, so both the tools I'm going to talk about today, the alcohol dashboard and the return on investment tool, both came from a data collection that we set up at the end of 2021 to capture the patient level information from the trusts about these alcohol care teams. So this dashboard was created to be used not just at a national level, but we also wanted it to be useful for regional, ICB and also trusts themselves to be able to look at their own data. So it has various measures within it, so just looking at activity within the ACTs, but also kind of onward referrals and outcomes as well, and you can see those on the right there, the metrics that we have within this dashboard, and I think we've added a couple more since I've taken that screenshot. There are lots of filters in this dashboard. You can look at certain date ranges, you can look at where these patients were referred from. Again, we wanted to make this as flexible as possible so that trusts and regions themselves could look at the data the way they wanted to. There's also a big focus on health inequalities within the dashboard, so we have a separate tab that splits each of these metrics by age, deprivation, ethnicity and gender. Currently, we only look at each of these health inequalities on their own, but we are planning on adding some intersectionality there. We've just been waiting for kind of low numbers to stop being an issue. So this is one of the tabs in the dashboard that we have, and it's showing kind of a pathway of patients through an alcohol care team. There's no set pathway, it depends on kind of what patient needs are. But you can see here we kind of look at whether a patient requires medically assisted withdrawal. and about 40% of them do, and where they receive that care, and most of them receive that care from the ACT while they're still in hospital. And then we also look at whether they were referred to a community alcohol service, so for discharge, for onward support, to continue to stay abstinent. So this is one of the charts that's in the Health Inequalities tab, and this is just looking at count of ACT referrals here, just for, I think it was just a year period that I chose. And you can see that most of the referrals are coming from the most deprived quintiles, which is encouraging. We know that about a third of alcohol deaths come from the most deprived 20% of the population. So it does have an effect more on the more deprived. So it does look like we're kind of getting the patients that have the most need here. You can also split it by age, and again we see older age adults more likely to be referred in, which is what we would expect as well. And we also split by ethnicity. We do have it split by kind of wider ethnicity. I think we have 18 ethnic groups or something like that. But again, especially if you're looking at kind of trust data, you do run into low number problems, and we suppress the data so it all just looks like 0. So we have added in these ethnic groups as well. And it is split by gender as well, and we do have a time series for all of these metrics as well to look at the health inequalities over time. So that was the dashboard. So the other tool that we created was a return on investments tool. So this was created to support trusts and their systems to kind of build a case for continued funding of their ACT services. And we used assumptions from kind of national data and case study data to create this tool. And I'll go into detail on how we calculated them, but the idea was to kind of be able to show the impact that these ACT services were having on the trust themselves and on these patients that were coming through the service. So these are the broad assumptions that we used within the ROI tool. They came from different sources I mentioned, so national costings, case studies, some other studies for like the percentage of patients we expect to be alcohol dependent. But all of these assumptions can be changed by the trusts or whoever it is that's using them to more locally appropriate values if they have them. So again, very flexible in how they can use this. Once they've changed any of the assumptions they want, it then calculates kind of how many patients can be seen by an ACT. So this is an example trust, it's not based on anyone. But we use the assumptions, the size of an ACT team, so the number of nurses, nurse practitioners, and the size of the trust, which we just base on discharges, to calculate how many patients we expect to be alcohol dependent that come through a trust within a year. The number of those we would expect to see by the ACT team, so in this case they have the capacity to see all of them, but that's not always the case. The cost to deliver the ACT service, which is based on the staffing costs of the nurses, as well as some consultant and admin support. And then the annual bed days saved, it comes from how many patients they managed to see in that year. And then finally, we can calculate the gross and net savings, the savings coming from the bed days. And these can help form a business case. We expect that this will kind of contribute to a business case and not be used in isolation, so they can add in any like additional information and local context as well. That's all I had. Thank you. Any questions?
So we have had a few through online, if that's okay. So the first one is, does the patient voice and do the patient voice and the views of workforce feature in the evaluation of the ACTs?
So we haven't specifically done any qualitative analysis ourselves, but that is something that we're looking at doing. And I think the bigger evaluation is looking at doing more qualitative analysis of kind of patient views and things like that.
Thank you. Any from the room?
Is there any in the room or whether around grabbing if so, why? Perhaps if you just state your name, where you're from, and then what the question is.
I'm Nikki, I'm from the local ICB, so Shropshire Telford and Meakin. I've already submitted it by Slido, but I was just wondering how you got at the savings of bed days figures.
That was from a case study from an ACT that had been set up much longer than the other ones in this kind of national rollout. that had some good data on their bed day saved for them that we used.
Hi, my name's Nick. I'm in the NHS England Cancer Programme. I'm interested in how you mentioned a little bit that you expected there to be older populations and you expected it to be most deprived. But how do you know that you're targeting the correct people? You know, what you are seeing, it matches up with what you're expecting, but are those, how do you know that's right?
Yeah, so we've looked at other measures as well. So in the inpatient data set, there's kind of codes for patients that are in alcohol withdrawal and alcohol dependence as well, and we can kind of look at the crossover between those patients and then the ones that are getting referred on to the alcohol care teams, and they also do tend to match up pretty well. So yeah, we've looked at a few other measures to make sure that these are the patients that kind of are the most need.
Okay, is there any more questions from the room? Oh, sorry.
Yeah, I put this on the slide here, so apologies for duplication. I'm Neil Bendel, I work for the Public Health Department in Manchester City Council. I'm just wondering from the inequalities information that you got in the dashboard, whether as well as kind of breaking it down by individual characteristics, whether you've thought about converting that into a single gap metric in order to track whether, say, the difference between white and non-white ethnic groups or between the most and least deprived, sections of users are actually widening or narrowing. So just kind of taking it one step further as well as breaking it down, looking at the gaps, converting it into gap metrics.
Yeah, I mean, that's not something we've looked at currently, looking at the gap between them, but would be something that would be interesting to look at as we kind of move forward with the analysis.
And can I just do one final question from online, which sort of is linked? Thank you. So somebody's pointed out that the data looks like non-white ethnicities are underrepresented. Has anything been done to find out why that is the case?
Not yet, I would say. I think we're now starting to use the data that's coming through on this dashboard in anger and starting to explore questions like that. I think we'd talk to our programme colleagues who would have the expert knowledge in who they expect to actually be the target cohort for these services, and then we can do some comparisons because the cohort might not just reflect the demographic makeup of the general population. So another thing we can take away there. Thank you.
That's great. Thanks all. So I don't think we've got time for any more questions, but if you just show your appreciation for Beth and Tom there. Thanks very much.